Hi, I wanted to talk to you today about the unintended consequences of COVID-19 on pregnancy outcome, particularly preterm birth and stillbirth. We probably all remember this day and where we were when we heard Scott Morrison announcing that Australia was going into lockdown. This was at the end of March in 2020. A lot of discipline-specific guidelines were produced again across the world during that time. In Australia, the RANZCOG guidelines produced some guidance for care providers and what they needed to do during COVID-19, as well as antenatal care during COVID-19. And those guidelines mentioned reducing, postponing or increasing the interval between antenatal visits, limiting antenatal visits that were face-to-face to less than 15 minutes, using telehealth consultations as a replacement to routine visits, cancelling face-to-face antenatal classes, limiting visitors to partner only or even not that while in hospital, and considering early discharge from hospital. And this one, which I think is particularly important to point out, that obstetricians were advised to avoid early planned birth unless clearly clinically indicated. Now, this has created a bit of a delicate balance. And the reason why I say that is that care provider guidance is only one aspect of maternity care. We need to also look at the kind of care and experience from the pregnant woman's point of view as well. So the Australian College of Midwives are actually quite nimble in putting together a survey that went out across Australia at the height of the COVID pandemic, the first wave. It is still going on, it's still collecting data, but this report was published when they were just below 3,000 women, and in that period of time they were asked about their experiences of antenatal care. And as you can see, the responses were quite telling and quite concerning, with women saying that they were receiving the worst care, disappointed with their level of care, the fact that no partners were allowed in their scans, and particularly being concerned about implications of what might happen if the couples were to get bad news during that time. And I think the one over on the far left, this one here, maternity care has been stripped back to if you're alive and so is the baby, that'll do, is a little bit, more than a little bit concerning actually. So you have to ask the question, what, if anything, has COVID-19 done to pregnancy outcome? And as I said in the introduction, I'll be looking specifically at preterm birth and stillbirth. So with respect to preterm birth, we heard from a group in Denmark who did a large study where they looked at the years 2015 through to 2020 and the period of lockdown in those years. And they reported a 90% reduction in extreme preterm babies. They hypothesised that maybe the lockdown was less stressful for women because of, quote, forced quiet time before and after the birth, less visits, less social obligations. But also embedded in their discussion as just a one-liner, which they didn't discuss further, was this, that it was possible that a larger number than usual pregnancies had resulted in intrauterine death. If we go to Ireland, we see the same kind of report where very low birth weight infants were significantly reduced. And they also proposed that maybe the socio-environmental impact of the lockdown had improved this particular outcome. And finally, a news report from Calgary in Canada, where they, a neonatologist said that he had noticed that births that were very premature had dropped by about 40%, and that birth weight was also much less common. Low birth weight babies were much less common during that same period. He hypothesised that social distancing might have cut down on general infection, less air pollution from fewer cars being on the roads, and not going to work or resting all might have contributed to this quite positive outcome. So, does COVID-19 have a silver lining with respect to preterm birth, or is it actually a dark cloud? Well, unfortunately, I think that it's a dark cloud, and here's why I think so. We know, and we've known for quite the longest time, that intrauterine growth restriction and pregnancy-associated hypertension are two big contributors to preterm birth. And the reason why they are big contributors is that they are also iatrogenic causes. So what I mean by iatrogenic is that a obstetrician looks at the size of the baby and says, actually, I don't think that baby's going to make it through to full term, and so I'm going to deliver this woman early in order to essentially save the baby's life. Similarly, with pregnancy-associated hypertension, both the mother and the baby's life are at risk in that particular scenario, and it's quite common for obstetricians to be so concerned about the woman's hypertension that he or she will induce labour. The way of resolving pregnancy-associated hypertension is to deliver the placenta. So let's look at stillbirth. In a large maternity hospital in London, they compared pregnancy outcomes from before the COVID-19 crisis and during the pandemic period, and they found the incidence of stillbirth was significantly higher during the pandemic period than before it. They also noticed something really very interesting, and that was that they had diagnosed fewer women with hypertension in the pandemic group. And I don't think for 1 minute that this is because there are actually less women with hypertension. I think that less women were being diagnosed with hypertension, perhaps because of changes in obstetric services. So their hypotheses were that perhaps this was a direct consequence of COVID-19, although they were quick to report that none of the mothers or of the autopsies of the babies showed any signs of the COVID-19 infection. They also hypothesised that maybe the mother was reluctant to come to hospital for fear of contracting the infection. And their third hypothesis, which is really the one that I think is likely, is that changes in obstetric services, reduced antenatal visits, ultrasounds, screening, all that kind of stuff that's so important to good antenatal care wasn't happening during the COVID lockdown, and therefore potential babies at risk were not being detected and the stillbirth rate went up. To a lower income country, Nepal, they were actually in the middle of doing a prospective observational study, and so they were already collecting data, and they just continued to do so in 9 hospitals in Nepal. And they actually found that their institutional stillbirth rate from 22 weeks, which is the definition of stillbirth in Nepal, increased from 14 per thousand to 21 per thousand, which is a huge increase. And more concerningly, they talked about the period during lockdown being a sharp increase from 8 stillbirths per thousand in week 1 to 33 per thousand in week 4. And they proposed that maybe the national lockdown had had an indirect impact on women and babies due to travel restrictions and fear of going to hospitals due to COVID-19, heightened fear of disease transmission, which might have stopped women from seeking care. And so they concluded that pandemic lockdowns threaten lives and jeopardise progress that had been made in the last 2 decades in lowering the stillbirth rate in Nepal. Liz Lorne, who is a well-known stillbirth epidemiologist, said of this study, collateral effects of such lockdown have been much more severe than the actual direct effects of COVID-19, especially for the most vulnerable in our society, pregnant women and babies. Then if we move to India, they also did a retrospective analysis from 4 hospitals during 10 weeks after the lockdown, compared with 10 weeks before the lockdown happened. And they also reported significantly increased in-hospital mortality amongst the pregnant women themselves, which is hugely concerning, late intrauterine fetal death and stillbirth during the post-lockdown period compared with the pre-lockdown period. And they proposed that maybe hospitals were perceived as reservoirs for COVID-19, that women were avoiding hospital visits even when they required tertiary level care, and reduction of availability of public transport during the lockdown further hindered access to tertiary care. And they concluded that the current case fatality rate for COVID-19 in India is approximately 2.9%, which is far less than that of other serious ailments. And we presume that many women with a complex pregnancy have died at peripheral centres waiting too long for a timely referral. And this consequence shows how public health emergency like COVID-19 can indirectly and adversely affect unrelated serious diseases. Back to a high-income country, Scotland is as far as I know, the only country in the world which collects data and publishes it fairly contemporaneously. So they're about a month or 2 behind actual time versus countries like Australia that report their perinatal statistics every 2 years. Scotland also report perinatal data every 2 years, but they also have this running tally of stillbirths that are collected much more frequently than that. So you can see from this slide that there's been a little bit of an uptick from the beginning of 2020 to the second quarter of 2020, such that you might think, yes, that could be just normal variation, or it might be something to be concerned about. Well, it seems like it might be something to be concerned about because the June and July information has just been published. And the stillbirth rate in Scotland has popped up to 6 per 1,000, where it's been pretty much hanging around 4 per 1,000 after 24 weeks for quite some time. In fact, Scotland have done fairly well in reducing their stillbirth rate over the last few years. So that's pretty concerning. Why it's happened is a subject of investigation, but it is concerning that a high-income country like Scotland has experienced such a jump. So what's happening in Australia? Well, the problem, as I said before, is that our perinatal data for this year won't be published until the end of 2022. And so we actually are flying completely blind in Australia as to what might be happening with our stillbirth rate. We do have some, quote, anecdotal evidence, which always makes me giggle a little, from the Australian College of GPs, who asked a busy obstetrician about his experiences of whether he'd noticed an increase in stillbirth in his practice, and he said no. Mind you, later in that same report, he said that he hadn't changed his practice much because he was afraid of pregnant women falling through the cracks. So if he hasn't changed his practice, then it's probably no wonder that he hasn't seen an increase in stillbirth in his practice. More interestingly, I guess, the Mater in Brisbane, which is one of our largest maternity hospitals, if not the largest maternity hospital in Australia, have had a look at their data for February through to June and report that they haven't observed any statistical differences in stillbirth. So that's good, although that word statistical does worry me a little because they may have seen an increase and it just not been statistically different. So just to finish, what can be done? Well, I think going back to what the Indian people concluded is true for pretty much across the globe, and that is, given these findings, there is a dire need for patient educational campaigns and the encouragement of public health officials, media and local physicians to address patients' apprehension and to convey that it is safe to come to hospital for maternity care, which if untreated has a higher morbidity and mortality rate compared with COVID-19 itself. Thank you for your attention.